Lymphoma Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the Lymphoma Hub podcast. Today we'll be hearing from Francesc Bosch from Vall, Barcelona Hospital Campus in Spain.
Good morning. During the last decade, we have a lot of new target therapies for CLL, and among them, the most widely used are the Bruton tyrosine kinase inhibitors, the BTK inhibitors. They are most widely used, and particularly the first-in-class ibrutinib that was the first going in clinical trials. Actually, the first trial started in 2010, so we're talking about 12 years using ibrutinib in CLL. So these drugs are very, very active in all the settings, in high risk, low risk CLL, and the safety profile is, I would say, more benign than the one we are observing with chemoimmunotherapy. Actually, all the trials that compare ibrutinib with chemoimmunotherapy, ibrutinib result in a better efficacy and lower toxicity. So ibrutinib has been compared against chlorambucil, against bendamustine, against FCR. So in all these trials, ibrutinib proved to be more active, including patients in considered low risk, like mutated IgHV patients. So as we have a new BTK inhibitors, the so-called second generation inhibitors, have acalabrutinib and zanubrutinib. Those are equally active. They have been tested against ibrutinib in the ELEVATE-RR trial, ELEVATE relapsed refractory CLL. Acalabrutinib has been tested against ibrutinib. The goal of the trial was to check for the progression-free survival, and if you look at the curves, they are almost overlapping. So the progression-free survival of acalabrutinib and ibrutinib are almost the same. And zanubrutinib has also been tested against ibrutinib in the ALPINE trial, also in relapsed refractory patients. And it seems the preliminary data with short follow-up, it seems that perhaps zanubrutinib is a little bit more active, has longer progression-free survival than ibrutinib. So we new data is, I think, is coming up. I hope in the following ASH meeting we will see an update of these results. So the difference between this first generation ibrutinib and second generation acala or zanubrutinib is the safety profile. It appears that some of the toxicities that are more prominent in ibrutinib are not appearing in acala or zanubrutinib, particularly the cardiovascular toxicity. The atrial fibrillation in ibrutinib is around 15% all grades, and it is, I would say, 6% lower in acala and zanubrutinib. Also, the hypertension is higher in ibrutinib compared to acalabrutinib and zanubrutinib. The major bleeding is quite similar. And infections are, it seems that infections are a bit higher in the zanubrutinib because we are, at least in the preliminary reports, it seems that zanubrutinib is inducing a higher percentage of neutropenia. So we have similar efficacy, we have a different profile of toxicity for these drugs. So how to choose between them? First, we have the good news is that we have three very active drugs. Ibrutinib is maybe the one that we have a longer experience. We have a longer follow-up with a clear benefit over chemoimmunotherapy. It has been used in more than 3,100 patients. So it's probably the most well-known drug in this setting. Those modifications are possible. We can use a second-generation BTK inhibitor as a backup. Acalabrutinib, it appears as efficacy, and the efficacy is similar to ibrutinib. The safety profile probably is better. The proton pump inhibitors cannot be used at the same time than acalabrutinib. There is a strong interaction. It's inducing less atrial fibrillation for sure, less than maybe a 6% less atrial fibrillation, but the experience is shorter. So the follow-up with this drug is shorter. And the same with zanubrutinib. Zanubrutinib is the last one appearing. It's not yet approved by FDA. It probably is going to be approved soon because of the Alpine data. And it's the safety profile is similar to acalabrutinib, and perhaps more active than ibrutinib. We have to see the mature data for these trials. So how do I choose? I think we have to individualize the patients, consider the long-term efficacy, and consider the additional comorbidities of the patients. In case of cardiotoxicity, probably I would choose second-generation BTK inhibitors. If there is risk for infections, perhaps zanubrutinib is not a good choice. So I think we have to take individual decisions for the patients, given that the efficacy probably is the same among these three BTK inhibitors. Thank you.
Thank you for listening to the Lymphoma Hub podcast. We would also like to thank our supporters, Bristol Myers Squibb, Genentech, Insight, Pharmacyclics, Roche, Novartis, AstraZeneca, and BeiGene.
Lymphoma Hub podcasts, brought to you by Scientific Education Support.